Dr. ANASUA, ma'am, please continue. Please start. Thank you.
Yeah, good morning everyone. I will be presenting a case series on multimodal imaging of Coats disease with macular nodule mimicking retinoblastoma. So in 1908, George Coates first described the Coats disease as a congenital retinopathy in young males characterized by retinal telangiectasia, subretinal exudation, capillary non-perfusion areas, retinal detachment. Macular nodule in Coats disease has been described in Western literature and has been reported to have an incidence of 23 to 53%, but surprisingly, no study from India talk about macular nodule as a presentation of Coats disease. Like this particular study, including 280 patients of Coats disease, none of the patients were reported to have a macular nodule. So we looked into our 339 patients of Coats disease, treatment-naive Coats disease, and we found out that 7 of them, that is 2%, had a macular nodule at presentation, which were included for this study. We documented all these, and we found out that the mean age of these patients with macular nodule was 6 years. They were all male, unilateral presentation, the median best corrected visual acuity being CFCF. And interestingly, all patients were diagnosed with retinoblastoma and referred to our ocular oncology clinic. The most common presenting complaint was decreased vision, followed by squint and white pupillary reflex. The macular nodule was located in the fovea in majority of the cases or between the superior arcade and fovea. The color was grayish white, either it was dome shaped or bilobed, and there was subretinal exudation around the macular nodule in all the cases. There was pigmentation in 57% of cases. The second or third order retinal vessels entered the nodule and continued till the apex. 1/3 of them also had calcification. In the fundus, the peripheral typical telangiectatic vessels were noted, most commonly in the superotemporal periphery. There was subretinal exudation and subretinal fluid in some of them. Moving on to the OCT features, it appeared as a well-defined subretinal nodule involving the outer retina, RP, and Brooks membrane. The inner retinal layers were disorganized. The ellipsoid zone and ELM were disrupted. There was a lot of posterior shadowing surrounding exudates, no fluid. We could also note dense localized hyperreflective areas of RPE aggregates. On ultrasound, it appeared to be a eco-dense mass with a highly reflective A scan on the surface and also sometimes inside the mass whenever calcification was there. On fundus fluorescein angiography, at the macula, early and mid-phase hypofluorescence with focal leakage, indicating a vascular etiology, and in the periphery, the typical light bulb aneurysms with CNP areas were seen. Primary treatment for majority was laser photocoagulation and scleral buckling and external SRF drainage for patients with retinal detachment. At a mean follow-up of 8 months, the best corrected vision acuity was maintained in all cases with no significant vision gain. So just to summarize the differences that we noted from what characteristics are reported for macular retinoblastoma, these patients had xanthochoria, were older in age, all males, unilateral presentation, whereas retinoblastoma was in a younger age group and also had seeds or hemorrhage in AC and vitreous. Just a note on the nodule, this nodule is grayish white, the surrounding exudation is there for all patients along with pigmentation, whereas in retinoblastoma it's a fluffy white nodule with feeder vessels and calcification. And the periphery is the giveaway, look for the telangiectatic vessels there along with exudation. On OCT, it was a subretinal nodule, whereas retinoblastoma is a full thickness retinal mass. On FFA, there was blocked fluorescence because of the exudates and pigmentation, and in the periphery, there were the light bulb aneurysms and CNP areas, which was not the case for retinoblastoma. Calcification was more common for macular retinoblastoma. So this is the first Indian study on Coats disease with macular nodule. It represents a vascular process. Here we have first time described in detail the layer by layer OCT characteristic of these macular nodules. The poor prognosis is basically because of the degenerative changes in retina. It is of utmost importance that we are aware of the typical fundus appearance and adjunctive imaging features of this entity to differentiate it from retinoblastoma and treat appropriately. Thank you everyone for a patient listening.
This is a very interesting presentation that you've made, and really appreciative of the fact that you noted these findings. For my understanding, when you see peripheral telangiectatic vessels, so a diagnosis of Coats is very much evident. So, what made you feel that this study should be done?
Yeah, so the reason, as I said, all these 8 patients were referred to our oncology clinic with a diagnosis of retinoblastoma, and one of these kids have also received a chemotherapy. That urged us to do the literature review, and when we found out there are no Indian studies, so it's worthwhile to report the features, because despite that peripheral telangiectasia that is missed, and people do confuse it with retinoblastoma.
Yes, so I think a comprehensive indirect ophthalmoscopy
Absolutely.
in all these cases will make things much simpler.
Absolutely. And the exudation, which should have been the takeaway.
Yeah. So now that you've done this study, what do you think is like the one point where you would still confuse it with retinoblastoma?
Yeah, so the presence of macular nodule, as I said, it is very rare, like only 2% of our population had it, and like the pathogenesis is misunderstood. So for everyone here, the one finding, the macular nodule might look similar, though this is more grayish yellow compared to the fluffy white what we see for retinoblastoma, but what we should look for is the surrounding area of exudate. And what she said very correctly, the peripheral telangiectatic vessels should be looked for whenever in doubt to give away the diagnosis.
It means the B scan and the OCT findings and the clinical picture, the peripheral examination, all these things will contribute
Yes.
to differentiate between these two.
Yes.
Thank you,
Thank
ma'am.
you.
Wonderful.
Thank you.